normally this is where I push that cotton so that I can avoid that flash. So if I go back to this photo here, so if you look at it, so there's good, there is no flash here. So this part is good, I don't see any flash. So when you're cutting the cavity as well, try and go as far as here. Alright, so this, don't go, some people are cutting all the way down here, don't do it this far, but just below the contact area. So I would cut all the way from here and try and cut different cavity shapes. Sometimes do bevel on the labial side, steps. So challenge yourself if you can. So the first thing that whenever you're assessing, I would put my mirror just behind this tooth and I see this part. Is there any flash or not? Is there anything I can see? Which they will mark me down. Okay, now after that, of course, tooth restoration junction, which is very important. It should not be detectable. Now, it's very hard to remove this part. So always make sure that you use a flowable. Just don't use a lot of flowable, but just a palatal shelf, you can easily do it with that. Now, on the back, if you have porosity, it's not a big deal. Like, so if you look at your rubrics, this is a class 4. Where is my class 4? So there's that now the slightly different. So I've just put different photos for each tooth. So if I go here, porosities. So if it's an anterior tooth, now if you have a porosity on the front, right, automatically you'll go into borderline, which may affect the aesthetic. But if you have a teeny bit, right, on the palatal side, it's okay because it's not going to affect the aesthetic, it's not going to affect the durability. So where that porosity is matters, all right? So the first thing, as I said, we look at it if it's a class 4 or class 2, polish, very important. So on the front, of course, we want not only highly polished, gives a very nice look, but also if it's rough, that generalized roughness, and so here you can see I've mentioned all the different reasons as well what it causes for this plaque retention. And on the front, so this roughness on a class 2 will impact mainly from a plaque retention perspective, bacterial perspective. I mean, aesthetic is least important at the back, but the roughness is more from a functional point of view. But on the front, along with function is aesthetic as well. So going back to this one, if I can look at the front part. Okay, it looks two different. So there's 2 different shades. So I guess you used 2 different composite or flowable. So never use flowable on the front, please. Always packable. Just the palatal shelf. It's fine to use flowable. A lot of flowable will get you in trouble, which is one of the criteria here as well that you can't use. Now, do you see? It's like in the restoration integrity, it's like either it's fractured, either it's loose, it's missing, or even excessive flowable. Now, some people are so scared, they've started using packable even on the palatal side. As long as you're comfortable, you can do it. But if it leaves a lot of porosities, incremental lines, so important. Now, this is where basically, now, after roughness polish, porosity, we're talking about incremental lines. I don't think so many of you are even checking this out. This is 3 points. Now, incremental lines is basically those slight lines that you see. Now, why is it important? It's not just from an aesthetic perspective. Let's say on the front, yes, aesthetic will be compromised, but what if I have it on the palatal side? What difference would it make? Now, what it does is these are basically the layering. These are the weak areas of the composite. So when you leave it, why would they mark it down? Because this is the area where the composite is the weakest. It will fracture, especially. And when you make, so do you see? Now, this is, like we talk about high spot at the back, this is going to be a high spot on the front. So incisively, do you see how it slopes down? Now, when you have an incremental line here, and you leave a high spot on the top, what will happen? It will fracture. The composite will fracture. So from an examiner point of view, remember, it's not just about ticking the boxes. It's understanding the criteria. This is, at the end of the day, it's going to be a patient's mouth. So there's 5 sections in the first block. In composite, we talk about polish, 2 porosities, all right? Then the third one in this category would be incremental lines. And the fourth one, we talk about curing, phase and curing. So this is where basically have you fully cured or not? Sometimes what happens is when you're finishing the composite, you get a lot of splashes of, so it's always run water if you can. Then you have that white, unfilled composite on the surface where they will mark you down as well. I mean, it doesn't happen very often though. And again, why is it important? Critical. Because if if it's unfilled, it's cytotoxic for the patient as well. So some criteria are harmful from a biological perspective, from a medical legal perspective. So think about from all perspectives. So when you are aware, then you know which criteria to focus, which one not to. Now bond, flowable, or composite. So debris that we talk about. So again, make sure that we use bond, of course, but before you cure, make sure this area is clean. All right, especially with the new platinum teeth, it's very hard to polish those ones. You don't want to damage it. So usually you will find a lot of debris on the surface. As you can see, I put some photos here. At the back, normally we also see like the stains as well. And look at this, significant debris or excess, which affects the flossing or function. Now, what makes the criteria different? Whether the patient can manage or whether the practitioner needs to intervene. That's the most important thing that we have to. If it's minor debris, no problem. So 5 criteria in this block. Now, those were one box, one section. 5 means 3 times 5, 15 points. Those first category. Now we'll talk about another important section, which is, now this is where we're worried about the caries perspective. So tooth restoration junction. So I was just doing an assessment the other day. Now sometimes if it's slightly detectable by probe, it's right. But what happens is if slightly detectable, some candidates they put flowable here. Now access is going to get you more in trouble. So slight catchable is fine. So when you send these photos, I'm always looking at the margins to see. Of course, it's hard to judge it on the photo. Now, how do you know if it's access or how would I know? I think the most difficult question to answer is like when I'm doing self-assessments as well. I find candidates, they cannot differentiate if it's an access, which is now covering on the tooth, or if it's a deficiency, right? Now, the both of them will have different sort of management that you would do. So how would you know? So if my technique is different, so comparison. So let's say if I'm looking, if I see like there's a little bit of material over here, but platinum teeth, you can't really see it properly, they're very similar. So first, I will look at the restoration. I'll move on this side, and then I will look at from this side and see if the restoration is sitting a little bit higher than the tooth surface. All right. So if you see that tiny step in this area, that means you have an access here. Okay. Now, if let's say you don't see anything, so when I look at it, I don't see any step, then I'll come around this side. Now I'm comparing the tooth with the restoration. So I'm going to start looking from this side. Do I see a step? Do I see this tooth slightly higher than the restoration? If it is higher, then you have a deficiency. All right? Then it means you need to fill it up. You see, excess needs to be removed. Deficiency needs to be filled. Now, this is going to be more problematic when you're dealing with this area. This is where you tend to see a lot of that excess deficiency discussion. I mean, I can see it from far away usually without even loops. And that's what I do. I put my mirror here, I put my mirror here, and I look at it and I compare from both sides. Which side I see that step. Even for cervical overhang, until unless you put your mirror here exactly just right behind the tooth, as I call it, sunrise. So if you put it just behind the tooth, the light is flashing from behind. Even the tiniest flash, you can see it. It will like kind of be so pronounced. You can easily see that. So it's very important. This is very important. This is like non-negotiable, okay? Because this is the main thing. So slight detectable by port, still okay. Don't go for it. If it's not detectable, amazing. But if it's light, it's okay. Let it be. Now, excess or deficiency, which is like 1 or more points, which is less than 0.5. Now, these two are very tricky. Now, how would I differentiate? So, the catch would be when you run your probe, but you can't see anything. You feel it. So, that's satisfactory. But if you see it, teeny bit, you're automatically into borderline. Because it's hard to say 0.2, 0.3. If it's pretty obvious, of course, it's unsatisfactory. Then cervical overhang, as I said, look at these ones. So these are just few of them. Look at this slightly sitting outside. There's another one. So here, I think the photo that was sent to me, this one doesn't seem to have it. So we will look at from both sides. No, it doesn't look. So from this side as well. Nope. Yeah, so make sure you push a cotton in there. It's my technique. I call it a fairy tale technique. So I push up. This is where I put my wedge. Then I will use a cotton. I will insert it in. You can leave a long tail outside of the cotton, and then with that long tail, I just hold it behind the strip, and basically that makes sure that I don't get any access on this side. So it's a very good technique if you want to try it out.
I'm sorry, Dr. Nadia, to cut you off, but many candidates, including me, cannot see your screen, and we have no idea what should be done. We don't know, and we have some limitations, like we cannot open our cameras. Some of us actually cannot unmute themselves. That's why they are not saying that as well.
No, sorry, but I did update the app and it worked. Yeah, try updating the app.
Oh, okay. So update the app. Otherwise, you're just going to keep hearing me.
But it's true, Dr. Nadia, it's something new. It was a bit weird when we opened it, so it wasn't like usual. Maybe you did update maybe in your side you updated it. Thank you.
I just did the normal stuff. I didn't do anything much on my end. Okay. So, yeah, so guys, if you can update it, great. If not, I don't know what else to do.
Hi, Dr. Nadia. Yes, I'm also facing the same issue.
Okay. What do we do? Should I just, okay, let me stop and see what was the issue. I mean, I made it exactly how I did it. Ah. No content only screen. Do we have any tech person here to guide us on this? I have no clue.
Hi, Dr. Nadia. This is Zinera here.
How are you?
Yeah, okay. So just listening. So I would recommend everybody, whoever's facing an issue, just log out, restart the app or shut down your computer or update, and then make sure you're logging in before you click on the link for the meeting. That might help.
Thank you so much. It's like in life as well. Sometimes when it doesn't work, take some space. Okay, and I'm just looking at the back end as well to see what things might have changed. Not. I'm looking at my settings just to see if I need to. Okay. So anyways, I'll just continue for now. What else? There's no other option because there are other people can see. I'll just share my screen. And 8 o'clock we'll start with the OSCE discussion as well, the new case. All right.
Nadia, can you please repeat that high point part that you showed in this photo where you mentioned that there would be like a high spot and how we can like make that slow?
Oh, yeah. I'll come to that. So that's the other criteria. So we're talking about blocks of criteria, okay? So block 1 was polishing, our porosities, incremental line, resin curing, and debris. So remember, 15 points, that's our first block. It's all about aesthetic, it's all about the texture of the composite, how it looks. So on the front is even more important. Now the second block is more functional, so tooth restoration junction. Then next one is cervical overhang, as we said. So I think in majority of the criteria we're playing with 0.5. Less than 0.5. You see, overhang is one of the most commonest reason. Many of you don't even pay attention to this. This is non-negotiable. This is like a major, major thing. Because now we are compromising the gums, we are compromising the tooth. This leads to periodontitis. Basically, patient paid you money, and what you did, you cause more trauma and damage. And now why this is important, I'll take you. Now, tooth restoration junction and cervical overhang. Now, do you see in the same category, I have placed damage to the adjacent tooth and the assessment tooth. Now, the problem here is when you leave that access, and now when you try to remove it, either you will damage the tooth next door or mostly it's the same tooth. That is a medical legal issue. This is major. This is a very important. Now, you damaged a part of the tooth that was perfectly fine, and you know that enamel is important. Enamel wouldn't just grow back. So when you remove enamel, what will happen? The tooth now is even more prone to decay. So here in these areas, before you cure, make sure there is no access or learn how to remove it very gently. That's what I'm saying. Before you add any extra layer, when you see is it deficiency or access, first see, identify the problem before you fix it. So here, damage to the adjacent tooth and damage to the gingiva. Now, gingiva, you wouldn't be causing a lot of damage to the gingiva with class 4. Beginning of the exam, 10 minutes, they give you, when you guys enter the technical simulation room in the first 10 minutes, there's no marking. They ask you to, look inside the mannequin's mouth and write down, document anything that, you want to tell the examiner. So, if I were you, if I'm getting a class 4, because damage to the adjacent tooth and damage to the assessment tooth is such an important criteria, I'll make sure I scan these areas properly. And even if there's slightest scratch, anything around, I'll document it. I'll let them know about it. And same thing when you deal with caries as well. Damage to these teeth is very, very important. With the cotton.
Doctor.
Yeah.
Sorry. How would you recommend to remove this excess of the interproximal there? Because I find that I'm having this issue, but and I didn't use the cotton, so maybe
that's why you get access.
Yeah,
that's the problem.
Yeah, and then after having that, I find it really, really hard to remove it. And because when I try with a disc, I always go to the gum, to the gingiva. So do you have any
I have it on an online portal, I should say. But then on that, no, I don't think so on the portal as well. I have it, but I can take a photo tomorrow. Those that have attended on site with me, the moment I taught them this technique, there was a massive difference in the way. So I call it as a fairy tale technique. That's my technique. So just put a wedge, all right, and then roll a small piece of cotton, make a string. Then using my golden instrument, I push it in. I push a piece of cotton in there with a part of it kind of staying outside, and then I keep checking and I make sure that it stops just below the contact, just below the junction. Make sure that it's not sitting higher, because then you will have a deficiency here. And then I leave that dangling tail because also when I'm holding it from this area, I will get access on the side. So the idea is that I press my cotton while I'm pressing the band. Then no access here, very, very slight and very minimal here, which is easy to remove. And in this area, then I can use my strips because it's so small. Then I'll remove it with that generally.
Thank you. But in case if it's a bit too, let's say it's too much, how would you recommend to remove it? Just maybe remove the whole restoration and do it again?
No, I wouldn't. So anything that I would be using at the back would be my enhanced pointed. So you know the main pointed part? So I would keep it exactly where the flash is, on the top of it. So my aim is to put it there, exactly pointed, and then run. With that, I try to reduce the quantity, the amount. Reduce it, and once it's manageable, it's a very small amount, then I use my strips. Okay? Just make sure don't touch the tooth. This is major area. So, or at the back, I would try and avoid using disc. Now, for a couple of reasons. When you use a disc, now I'll go to the other criteria as well. So in this block, we have four major important things, medical legal. Tooth restoration junction, cervical overhang, damage to the gingiva, and damage to the tooth. So that's my block 2. So do you see like how easy it is now to remember your rubrics when you're doing your assessments? Now block 3 for me is the proximal area. Now this is where your tightness comes in. Now this is very interesting. This is where I'm going to go back to. So if you look at it, if you look at the tooth here, so this is basically your, I've just taken some photos. Now, you can always lower the speed of enhance. You can play around with enhance from the foot pedal, but make sure it's pointed. And if your enhance is rounded, I have a technique how to make it pointed as well. You keep use the same enhance, I make it pointed. So if you look at it anatomically, look at this. Where is the contact area? The contact area is never on this side. Majority of the candidates are forcing the contact labially. Look at it. We are talking about, you know how these days we're having those curved screens as well, the beautiful curved screens, because, so same thing in the mouth, everything is kind of slightly, do you see how it kind of dips down? Now the contact is more palatally. So this is why when you are making that palatal shelf, so this is when you're making that contact area. This is where you're making that marginal ridge. After that, you cannot do this. There is no other way. If you did not make your marginal ridge, just take this restoration off like another one. And when you're practicing at home, I would suggest just make palatal shelf, then break it. Don't make the labial one first. Make sure you master this really, really well. Look at this. This is beautiful. Look at how it's sticking a little bit outside. So that looks amazing. So where is the, no, it's flat. Okay, if I look at this from the top, look at this. Now what happened? This is what I was talking about. This is, I feel like, the restoration, they're leaning on the next tooth. Like you're leaning on the wall, relaxing. So this is what happens. I see it. Now, how it should look like this. Now there are few criteria when I talk about proximal area. Now in the proximal area, there's a criteria called proximal contour. So this is proximal contour, and then it goes on the other side as well. And then we're talking about proximal tightness, which is your contact area. It should be. And again, this is another issue. You need to make sure it's in the right position. So see, it's more palatal. And also, I see a lot of candidates making such big, wide contact areas. So where is it? Not here. Sorry. Not here. I think I had it. Yeah, so if you look at it on the front as well, the contact area is more at the junction of the incisor 1/3 here. All right, and it's not really broad. If I have a further, a better one, let me see if I have it. No, I don't have it here. But in your jaws, I want you to look at, maybe here, look at this. Yep. Now look at how these two are merging. Look at where they're meeting each other. And then they're separating on the top and then below. Now, let's look at this. If I go back here, you see how it's leaning on the tooth? This is what happens, right? Now, this is the fronted. Look at this. How it looks flat. We're talking about a static zone. So, criteria number 1, proximal contour on both sides, right? Then, number 2, tightness. And now there's another very important rubric. I don't know if many of you haven't even seen it, didn't bother. I've been asking everyone about it. which is called morphology, other surfaces. Have you guys seen this? What does that mean? Morphology, other surfaces. What is this? Now, on the class 4, what that means is this. So that means that at the back, there should be a differentiation. So this is your marginal ridge. You can see it's slightly sitting higher, and the lingual fossa, it dips in this area. It's not flat, right? And on this side as well, on the labial, I'll show you the anatomy. So if I go back to the anatomy, where's the anatomy? I'm actually enjoying technicals. It's really interesting. All right. So anatomically as well, if you look at it, so there's a difference. Mesial, and this is the distal sign. Now, I don't know if many of you have seen, this is what we call as mesial line angle, transitional line angle, okay? Now, this is such an important one. This is what I'm talking about. Now, just as you reach the line angle, then it starts to drop down. Do you see? It curves at this area. So if I talk it from the top, so I'm showing you, look at this. Now, this square area, this is flat, but below this line angle, it starts to go down. Now, that's the problem. Many people are not looking. Do you see that flat? Because this contour was not there. Now, this is 3 points. It's called morphology. This is such an, especially on the front, aesthetic, functional, redondo. Now look at these ones. Look at how it's sticking out. Look at this. Right? Look at this, how flat it is. So why is it important to do that? Because again, patient will not, their tooth looks terrible, right? Now, why it happens on the palatal? When you use your soft flex. I would never dare to use the disc at the back. Unless sometimes there is access, if you have no option, do it, but where possible, go with strips. In the middle, or any access here, enhance, in the middle, enhance, even the slopes here. So I use my enhance. So when I use my pointed enhance in this area, when I remove the flash, then it becomes ball around. Then I put that ball, not here, just in the middle. Why in the middle? Because with this, I'm trying to create that curvature. So I wouldn't touch this. I put my enhance in this area and remove. And as I do it, I slide my enhance down. Put it over here, slip it down. Put it over here, slip it down. And when you do that, what you will see is this. So if I show you incisally. Now, class 4. Why is everybody making a step? That's my problem. When you make a step, you're creating a high. This is where your lower teeth is going to start hitting into it, right? It's really against your anatomy, which is again another criteria. So if I go back here, so here, if I look at BC, it's straight. It's not straight. Look at this. So what I do is I put my hand, the ball here, and then I slide it down. Put it here, slide it down. So 2 functions. I do it in the middle so that I can reduce this part, all right? And then also I make my lingual fossa. So that's at the back. Now what about the labial side? What do I do on the labial side? So on the labial surface, when you have any access on this side, so for example here, now you see that access here. She has. I can draw this. I'm going to try and see. Okay, I'm going to copy this on MS Paint. Paint. I'll show you how to do that. Alright, this is better. Now, so if I go with this, now what I would do is, this is the line, it's my pen, this line, right? So this would have been my line. So keep your disc at this angle, I call it 45 degree. So if you keep your disc straight, which I find an issue, so what happens when we have people are doing composite, they are keeping their disc straight to remove from the proximal area. Now 2 problems when you keep it straight. 1, great chances, high chances you will get rid of your contact area. you will lose it because now you're pushing it in there. And 2, you're making a flat surface, like a box. Look at that. So your outcome will be like this. That's not anatomy. So what do we do? So if that was me, I would, so for example here, I will put my disc at an angle like this. So, and use smaller disc. There's, light orange if you're scared. I mean, I use a darker orange, but lighter orange, smaller disc, Soflex, and then start removing from here. Don't go near the contact. Stay away from the contact, but just in this area. I will remove it. And how far I would go? I will go all the way until, sorry, my paint. I will go all the way until here. All right. Don't go, contact should be in this area. This is the contact. So you're allowed to go all the way until here. Remove it. This area is all access. This is access. Right? So with this, not only you'll see that will be a massive improvement, that square box appearance will disappear, but also, you see, it will go away. Now that's so 2 areas. So when you're doing your finishing on the ladle surface, I'll make another video. I know on the portal the video was good, but I'll do another one with all these tips as well. So I will first remove it. I never remove it from this side. Knowing the steps is also very important. I find that candidates just go random. They just go first finish from here. Now, if you start removing from this part initially, what will happen? Sometimes you might over reduce it. All right? So I like to remove normally from this part first so that I can create that line angle. All right? Remove any excess. So once that line angle is nicely, beautifully pronounced, so this is now going to be my, at the same time I'm making, there's 2 criteria, proximal contour, 3 points, and then I'm trying to enhance my morphology, other side, which is the other criteria, that's 6 points. And now, if I have access on this side, what do? Remember, this is flat. If you look at from the top as well, you see from the top, it's kind of sliced towards the incisal angle, it's flat. So from this area to this area, now I'm going to brush with my same small disc. I will start brushing it towards the incisal edge, just here. From here to here, this part. So when I brush it down, with that, what I'm trying to do is create this part. So put my disc here. This is how I'm going to divide. So put my disc here, slide it down. Put my disc here, slide it down. This side I created with enhance. This side I will create it with the disc. So always step by step. So first, again, everybody's different. I always go after my flash. I remove my flash on the back. I make sure that there's no junction detectable. I make sure I create my lingual fossa and the incisal edge. Then I curve buccally, and then here I create that line angle. Then I remove this part, incisal, pretty much that's done, with class 4 that you do. And that will be, now of course, incisal edge will be another one, which is this one. Incisal edge and incisal height. So height, again, make sure you follow the neighboring tooth. Now with these new teeth that they're giving you, remember it's not straight. So it's kind of slopey in those new platinum teeth. I mean, I don't have a photo here. But you need to follow, and it should meet the tooth. And also line angle here, incisal angle. Look at all these amazing shapes that we have. All right. So do you see how, look at all these contours. So when I ask somebody, can you please assess? I find majority, and that's just my observation, there's only 5 criteria they check. The first thing they will grab is a floss, and they were like, all right, and then, it's a very satisfying sound. I know we all love it. And then they go, oh, look at the incisal height. Okay, incisal height is good. They look at the contact area, and I see this big contact, the filling is leaning on the tooth. That doesn't bother them. They're like, fine, as long as I've got a contact and the height is okay. Then they quickly go with their probe, check the junction. On the back, they check the junction. And then they say, oh, there's no porosity, done. I'm like, really? Is that it? Yes. So this is where the problems are coming, okay? So categorize them into sections. All right, so here, proximal contour, morphology, incisal angle, incisal height, and same thing on the back we do it. So that's this category that we go, and the proximal tightness. So posterior composite. Now going back to the posterior composites.
Dr. Nadia,
yeah.
Sorry to interrupt. Do you have any tips for removing excess on tooth restoration junction?
Well, it depends on how much you have. If it's on the label surface, we did it the other day. So one of the candidates, we were doing a class 4 and she had some excess on here. So what we did was I was showing her to use a light orange disc and put it exactly where that excess, not on the tooth, just where that excess was. And I said, brush towards the restoration. Brush it.
Oh,
gently. I never go from restoration towards the tooth. I will move away. Okay? But to a point where there's a tiny area left, that one I will flick it away.
Oh, okay. Thank you, Dr. Nazia.
Dr. Nazia?
Yeah.
Is it possible to, when you get time, to kind of make a short video for us on how we can make those proximal contours? Because it's really hard for me as well to kind of create that curve around, and even that skirt. Like it just looks flat, and I'm not sure how to make it. I know it looks flat, but I didn't know what to do about it.
No, do that. So that cotton technique that I have, so I'll be uploading it there on the portal for you to see.
And for the slope as well, please.
Yes. And it's very simple techniques that I've been teaching. Like, literally you can do composite in 30 minutes, less than that. It wouldn't take too much time. Now, posterior, same thing. Now, when we look at the posteriors as well, same kind of rubrics that we have. So I got the order of molar. There was somebody saying,
Dr. Nasia, before you start the posterior, can I please clear it out with you? I've had this situation in the exam where a tooth was given anti-restoration with the tooth rotated, and I have called the examiner and pointed it out and said I am going to have difficulty restoring it as per the criteria, and I was told treat it as a clinical situation. I thought maybe I was one off because I've had these experiences before, but in my batch there were at least 3 or 4 other people who were saying the same thing. I did manage to catch up with them after the exam, and I believe all of us had rotated teeth. And the composite feedback, I failed the composite, and it came back with proximal contact contour, everything. And I was just going by, I should just do the normal anatomy because I couldn't really understand what was the expectation in a rotated tooth. If you could just maybe shine some light on that and tell us what...
Was it the premolar that was rotated?
No, it was the anterior. It was 2-1 and it was, it was more or less in a bucco-palatal rotation.
Okay. So, so look again, when they are going to be rotating, these are clinical scenarios that they are creating for you guys. So was it just that tooth rotated, or was the one right next to it as well?
No, it was only that tooth.
Okay, so anterior one, that's weird to do it. But whatever that is, I will try and replicate it. Now, what did you do? Did you try to go with a normal anatomy?
I did, and I felt that the lateral was, somewhat in the middle of the margin of what I was recreating. I don't know if I'm making sense. So I tried to restore it as per normal anatomy, but I felt the lateral was sitting in the middle, which is not something we want to ideally achieve. It would trap food over there in a clinical situation. And there was also excess because the lateral was coming in the way when I was trying to hold and mend that mylar strip.
Yeah, actually, I got also the rotated tooth as well in the exam.
Quite a few of us are getting it.
Yeah, and I pointed out to the examiner, I did a contact point even though the shape of the filling was so funny because I had to do the contact point, but I passed the task. But I told the examiner I will not be able to do the criteria, and she said, this is your patient, do it as a clinical situation.
This is the critical thinking area. This is what I've been investigating now in technical. So when they are giving you guys tight contact, loose contact, rotated tooth, buccally impacted, they are creating impacted canine work cases for you guys. They're giving you perio patients. Did you guys know in technicals you were getting these? Right? So in a normal patient, now this is where I'm coming back to. The ideas then they don't work. Look at the most important thing. Remember how I said, where is the contact point that you should create? Right? Focus on the contact area. Like if you see, if you're making it with the lateral, it's not going to be higher. You see, slightly down. Make sure that you're following the same tooth contour. Like one of the girls, I was assessing her work as well, and she was showing me the interior. So one was the normal teeth, the other one was platinum. And then, you know, in these teeth, like we had, it's a straight line, and in the platinum, it's a little bit more higher. But she just followed that particular tooth and not the right and the left. What was happening? And I said, look at it. If this was this patient, now what I'm looking at it is one tooth is shorter and the other one is longer. Is this going to be acceptable by the patient? No. Right? So that's what they're doing with you guys. They're giving you these rotated. So just look at the tooth, and let's say if I'm doing this side, I will use this side as a reference. This is going to be my reference area. Right? Because these are two mirror image of each other, right? So create it like that. But I'll show you. I'll make a video of that as well. How to do this part. Now, I'm just mindful about the time since we're running short. So I'll quickly go through the back. Now, when it comes to the posteriors as well, again, now here at the back, as much as we don't care much about the aesthetic, we're more focused on the function at the back. And what I tend to find, so I call it like this. So when I'm doing an assessment, I say, okay, first, let's look at the relationship of the filling. First, what is the quality of the restoration itself, and where the restoration meets the tooth, right? I'm interested in all those junctions, all around it. So where it meets the tooth, then what is the relationship of this restoration with the neighboring teeth? Now, this is where we talk about the contact area, the proximal contour, cervical overhang, all of that. And then the relationship of this tooth with the opposing jaw, which is also very important. So going back to the photos that I've received. So whenever you're assessing yourself, when you do composites, yeah, there's a lot of, okay. So when you're doing, making this tooth, I want you to look at the tooth right next to it. When you're making the upper first molar buccal cusp, I will use this tooth as a reference for myself. Where should I go? So let's say the first thing when you put your Toffelmeier, or another thing, when I've seen many candidates using those matrix band and burnishing it. Did you guys know that when you burnish, I mean, it was good for amalgam, but when you burnish it aggressively, think about what's happening is it's causing scratches. Number one, I've seen sometimes the stains that go. And then when you're burnishing it so generously, then we have these amazing big broad contact areas. So it doesn't work like that for a composite. So if you're using your Toffelmeier, if you're using your band, I'll pop it around the tooth, and remember, where is the contact area? This is your KD stars, right? Where does KDs happen? It's always just below the contact. Where's the contact? This line. If I follow this line, this is here, right? Below it. So if I follow this line, this is where my contact area is. Just below, at the incisal. Now, the common problems I tend to see in posterior composite is many candidates don't know where the contact area is. They think that the contact area is at the marginal ridge. This I'm talking about. So sometimes we create it at the marginal ridge. It's not here, it's just below it. All right. So I think I have let me see if I have a better one. Okay, look at this one. So this is excess. This is tooth restoration junction. So there's slight access here. This is going to be borderline. This is 0.3, if I can say. This is 0.3 that I can see. Look at the marginal ridge here. So if you look at the anatomy, do I have the anatomy of the other tooth? Let me open my other teeth. So what I did was, as well, when I was doing my own exam, I sat down one day, just holding the these teeth in my hand, and I was just observing it, looking at the shape, looking at the texture, and where is it? So this is the contact area. Now this is something that, let's say they give you guys those really broad open contacts as well. So if they give you really big, wide, open contacts as well, that's probably they're creating a situation of stage 1 or stage 2 periodontitis. Now in stage 1 and stage 2, the tooth does not lose its contact. But what happens is below, this is where the bone is receding. So now you cannot follow the normal technique that you use in these situations. So what do? Double wedge it. So put a double wedge, because the last thing you want is an overhang. You want to create an overhang, and then burnish it exactly where you want the contact to be. And I think it was not here. If I have the no, I don't have it here. So the contact is here, literally here. Okay, and then from above it starts to goes 45 degrees. So if you guys aren't part of my online technical, you might have seen how I did it in the video. So I use a microverge, a microtip, and then the golden instrument. That's it. These are the two things I use, nothing more. And then that's the whole idea. So first I fill the proximal boxes with flowable. And then the next thing is I create the first marginal ridge and the second marginal, and I go all the way just to here, from here to here. And how do I do it? So keeping a small blob of opposite, and with microtip, I push it towards the wall. When I push it towards the wall, what happens? From the top, it starts to roll over. Because you need rounding. That's when I get that rounding. And then later on, I don't need any finishing here. This is a very dangerous area for finishing. So before you cure, make sure you don't have any access here. And it's like Play-Doh. This is like a Play-Doh. So, and then what I do, from the top, in order to make sure these are the same height, I use my golden instrument, keep it at 45-degree angle, and then I shape it. So again, keep doing it until I'm satisfied. I look at from the side, and I compare it with the neighboring tooth. Is this where I want my marginal ridge to be? This is how high I want it to be. Then I cure it. So all the way till here. And then I do the same on this side. And then on the shell for the cusp, again, I put a blob of a little bit more, again with microtip. So I keep pressing it against the wall. I keep pressing it. Oh, I forgot to burnishing. So make sure, don't forget to burnish. Here, just that point contact. Now here, then I press it against the wall, and where I want my cusp tip to be, I try to keep that area a little bit higher. And then once I'm happy, I cure it. Now it's just like a shell that we created. I think I had the video as well on the online portal. It's running short of time. So in the portal, I'm sure you guys would have seen that video that I've put it there. Now that I've created the shell, now the next most important criteria is, remember how I spoke about morphology? Now the same morphology applies for class 2 as well. This morphology, other surfaces. This is always my favorite area. Where is it? Yeah, this. I don't know if you guys have ever seen this criteria. Now, what does that mean? What is this criteria? So morphology, other surfaces for the back teeth was, if you leave excessive depth here, excessive, then it goes automatically in unsatisfactory. Now, how do you end up with those really deep grooves? So again, it's just my observation. I've noticed that usually when you don't do flat pack, so where do I have this is good. So normally what I do is, let's say if this is the tooth, I've just got a shell around it, then this is my reference point. So I look at this deepest pit, and then what I do is I put composite packable inside it, just push it down. I make it like flat, like this surface, flat, and I will keep adding until I reach this point. This is how far I would go, because I want to avoid this criteria. I don't want to have that excessive depth. Now, some people, they start from the base and they build the cusp. Look, I mean, if you do it, amazing. That's a good idea. I could never do that. It takes longer, high chances of either over or under, high chances I can, maybe move my central groove. So my techniques are pretty simple. So flat back, all the way until here. Now it's easy. As I always say, that we say rise from your ashes, right, in life. So here as well, my cusp tip. So then I start building my cusp, put a small blob here, and then I start pushing it towards. So I just make this part here. It's easy. Distance from here to here is so much simple, and just golden instrument, nothing else. So put a blob, and with golden instrument, keeping it 45 degrees, just press it down, and now the other criteria here in the same morphology is they said poorly defined, non-anatomical. This is your high spots. So what happens is that many times when I'm assessing, many candidates are leaving high spots. And you know that they're giving you non-functional cusp. The opposing one is functional, right? So high spot. So if you look at the shape of this and look at the shape of this, this is high spot, right? Now what will happen? The opposing tooth, you know that the cusp sits here in this space. So if you did a very shallow carving, where is that opposing tooth will sit? How is that possible? So just as you pay attention to the cusp position, the cusp height, you should also be paying attention to the high spots. You don't leave high spots because this is again 3 points. You will lose points from here. And also last thing is about how do I know where my cusp position is, or now also just like I noticed in the anterior teeth, where we're forcing the contact or we're forcing it on the labial side, I find that many candidates when they're making these cusps, literally it's leaning, it's as if the cusp is leaning at the back on the pillar. Do you see? This is the right cusp position, and just behind it, this is the second plane. So if you look at it, they're all in the line. Look at this. They're following a line. This is the cusp tip position. That's your other criteria. Where is it? So these are small areas that I find that, do you see cusp height? Yes, oh, you guys are amazing, no doubt about it. I've never had any problem with cusp height. Everybody's good. The first thing they do is they take the probe, marginal ridge, contact, cusp height, and I'm done. But I'm like, stick position, there's another criteria here. Where is it? Where would you place it? So next, when you look at your work, I want you to check it critically and see where you are keeping those cusp position. I don't have a right photo here. Look at this. This one is also leaning back. This is what I call leaning back. You see? This is wrong cusp tip position. This is wrong. Now, the cusp tip, look at this one. This is the cusp tip, right? And behind that, this was the second plane. So when you're reducing it, use the disc, keep it at 45 degrees. So not only you're creating that second plane like this, but also you're moving your cusp tip positions in the line. Look at this. If I follow the line, this is where it should have been. And if I follow, this is the palatal cusp. Look at this. Right? So simple anatomy. I feel like it's just all about anatomy, understanding. Also, make sure you look at it where these teeth meet. I know you guys are very finicky about the marginal height, but also do you see the distance where they need to meet each other? Here, I find this big, broad, areas like we saw in class 4s. Now, this is a very important area. This is where food will get stuck. So the contact is not on the top, it's just underneath it. And also each tooth, do you see how they meet each other? This is what we call it as proximal contour. When we spoke in the anterior, this was the proximal contour. In the back, these are the proximal contour.
Dr. Nazia, may I ask you a question about the height of the tooth? Sometimes they might bring the tooth a bit extruded or a bit intruded. I'm not sure if it's intentional or not, but
it is intentional.
In this case, shouldn't we place the height of the cusp according to the tooth itself, not the adjacent teeth?
Exactly. According to the tooth itself, because now the opposing tooth has adjusted to that position that this tooth is at the moment.
In this case, as a general rule, should we always make the cusp 0.5 lower if it's non-functional and 0.5 higher if it's functional according to the other cusp? Let's say 1/4. The buccal cusp is non-functional, so I will place it 0.5 lower than the palatal one. Would this be satisfactory, or should I be studying each cusp, how high it should be according to the...
Again, clinically, because I work with some ex-ADC examiners as well, I had some conversations about what do you guys know, what do you see, and this 0.5 slide wouldn't matter as much. I mean, as long as it's not sitting too high, right? So what you said is correct. Like slide up and down wouldn't make a big difference. If you're not sure, I would make it the same height or slightly lower. Okay? But the main thing is, like, how is your contour on the side? And it should not be leaning back. That's what my point was, right? So is this your cusp here or not? That's important, right? Even if it's intruded, even if it's extruded, unless it's outside, it's buccally impacted, or lingually, that's a different story, right?
Yeah, it should be on the occlusal table, as they say.
Yeah.
Yeah.
So if it's on the up and down, slide up and down, will impact your cusp height, right? But it's not going to affect the other things. But don't forget to, keep that harmony, that central line that we're trying to do. This is important, so they want to see how it goes. Yes. But these are all critical areas. That's what I'm trying to do these days, collect all those. I've got a kind of collection of these kind of things, which tooth they gave, how they gave, what to do, which is what we're doing in the technicals. Anyway, so they're over 8 minutes. We're going to finish our technical class now, if everyone's okay.
Doctor, I have a question.
Yep.
How we can create the buccal cusp with the Flemeyer? Can we put it like in the palatally instead of buccally?
With a Toffelmeyer?
Mm-hmm. To create buccal.
To create a buccal cusp.
Yes.
Yeah, look, you can go palatally. Some examiners, they don't want them. In my exam, they didn't allow me. So the other way is I would go sectional. One technique is band and band, or you can go sectional.
Okay.
I showed sectional as well the other day, how to hold it with a mirror.
Okay, thank you.
So when you come, I'll show you how to do it. So, or what we do is you put the Toffelmeyer. If let's say, like on my day, my exam, they said, no, you can't go palatal. They do, some exams, okay, they're fine. They said, go palatal, no problem. But I want you to practice all different techniques. Okay. Never just try one way. So, but I always practice band and band as well. Then I went buccal. And then where that gap was coming, I placed a sectional inside it.
Okay.
Yeah, you come around, I'll show you how to do that. But before that, make sure you create your marginal ridges first. Because before you make the cusp, create both ridges, then it's easy to put either sectional or do band and band. Alright, so let's go on with... Okay. Going back to our case, our favorite part. The new changes, the new case. So this is where we are. Okay, so the scenario that they gave us was drawing out case. I mean, look, I don't have the photo just yet. Fine. I've got the list. One of the girls, she shared the list with me. Thank you so much. So I will update you guys as well, so to see what tasks have been coming in the exam, what sets have been coming in the exam. I'm sure you all have been keeping track of it as well. But yeah, there's some new variations that we're seeing. Okay, so this is the case that came. Why do I have this one? Sorry. Okay, so this is generalized. It was more like a staining.
Hi Nadia, I cannot see anything on the screen.
Again, you can't see? Okay. I don't know what's happening today. I've shared my screen.
Dr. Nazia?
Yep.
Can we have a different link? It's really I don't know what's happening with this one. Like it's for the off key because the video is like sometimes coming, sometimes not coming.
Okay, all right. It would be the privacy setting. Okay, I'm assuming it's that. So it's preventing screen sharing.
Yes.
So it would not allow screen recording or screenshot.
No, I mean like we can't even see your screen.
Okay. So I don't know if that was the option. That is what's blocking. This would be the security that they have added now recently, the update. Why is it calling?
Dr. Nazia, after I updated it works. So maybe
it works, right? Okay.
After updating the app again.
I did update as well, but I don't know, it's not working. Okay.
Sign out, sign in. It's okay. Try it again. But of course, this will be uploaded on the website as well. So we're going through this case now, and we'll update this one as well we'll upload it on the website. So this case was about found out the name. Patient's name was Kim, a 28 or 29-year-old CEO of a 4-star hotel who attends your clinic today. She's mainly concerned about the appearance of her teeth, having noticed staining on her upper teeth. Now, it's coming on upper 1.6 and it's also coming on lower 3.5 as well. So we have now 2 versions, which made her worried. Now, in exam, along with having a stain on the grooves, there was also staining on the palatal side as well, you could see. And in the lower, you could see it on the lingual side as well. And in the lower, one of the candidates told me that it was 3.5, and there was a clear black line going in the middle of that lower premolar, and there was black line staining on this side, and the tooth behind it, 3.6 also had some stains on the lingual side. So she also reports bad breath. She mentioned she has been experiencing dry mouth and uses chlorhexidine mouthwash. So she's fit and healthy, currently taking Lexapro for anxiety. Now, tooth 1.6 had, okay, so I've explained. So gather information, discuss necessary investigations, and address patient's concern. So, what is this case all about? Have you guys looked into it? What are they looking for in this case?
Here is risk assessment and obviously talking about staining and the risk factors, dry mouth, and the risk factors for caries.
Yes, so there's some very interesting things about this case that I was looking at. Okay, so just giving a bit of background. So when they said that this patient was a CEO, I can relate to that, how stressful job it is. All right, so you don't have your own problem, you're dealing with 10,000 other problems. So it's a very stressful job. Now, with that amount of stress, so she was complaining, she had 2 complaints. 1, staining, and 2, bad breath, which is very important. Yes, this will be recorded for sure. This is recorded, and I think I'm recording it. No, I'm recording it. Thank you for reminding me. Thank you. I need a reminder for the reminder. Okay. So I'll just put it back. So this is the scenario. So what basically in this case that they are telling you, number 1, young individual, young age, high responsibility, not a good combination. And it's not a 5-star, it's a 4-star hotel. So maybe there's a lot of pressure out there to make it 5-star. Now, with all of that, we're talking about, public dealing kind of thing, right? Where she's interacting. And of course, when you're talking to people, your teeth will show up. And now they are showing us the lingual side or the palatal side mainly and the occlusal surface. Now, some candidates said that in 1.6, the examiner said it was hard to see if it was a composite filling or a normal tooth. And one of the candidates said that the examiner said, I had a filling done, 2 years ago or a while ago. So I wasn't sure if I would need the fillings again because of those stains that I can see. So patient was, kind of not sure about it. Now, why is it important what they're trying to do? Now, bad breath, this case is built on dry mouth, right? And again, what happens is halitosis. This is from TJ. They said that normally it can be transient or sometimes it's ongoing. Now, transient is by eating, raising the mouth with water, it will get away, but the ongoing, of course, is much more complicated as we have more bigger problems. So if you see here, it says the intraoral causes, which is the major one. 90% of the people that faces. Now that includes because of poor oral hygiene or because of infections. And again, we have these bacteria that are responsible. And the extraoral, of course, is because of, so now she doesn't have these issues. Now, one of this terminology that is quite interesting in New TG they've added is called halitophobia, which I think this patient might be having. So halitophobia is where a patient perceives that they have bad breath, but it cannot be detected by anybody else. Now, this is going to be a psychological problem. But we don't know at this point of time if this is really psychological or not. It's more like a body dysmorphic disorder as well. And also, this patient was on antidepressant, right? Patient was, because it was a very high stake. Now, I know antidepressant causes dry mouth. That on the side, it also tells you about who is this patient. So this patient had a very high amount of anxiety and depression. And this patient was not regularly taking the antidepressants either. Taking it on and off sometimes. And then patient was anxious. Now, what happens is, have you seen like some days, if you have, and that's the power of mind. Like on a day, I always say, always go into the exam, think like a winner, and even if they are smiling at you, your brain will differentiate. So it will tell that you're going to pass. It's a sign of good luck. This is like the universe giving you a sign, right? So for this patient being anxiety, even if the patient, anybody's covering their nose or just moving their head a bit, they might perceive, oh my God, it's my breath. It's offensive. So this is all in the head. That is the problem. Now, the most challenging part is diagnosing this and treating it. But whether or not, this is the cause. Now, another thing this patient was using was chlorhexidine mouthwash. Now, chlorhexidine mouthwash is a good mouthwash, of course, but it's given for severe cases, and we know it causes discoloration. I'm sure all of you would know. But something more interesting I was reading about it was that when we talk about extrinsic discoloration as well, there's a few ways we categorize it: direct, extrinsic, indirect, and then we have metallic, non-metallic. So one of the things was very important was that sometimes there is a chemical interaction of one compound, and they said that tooth staining was increased in individuals that are using high amount of chlorhexidine, as we did talk about it, which was happening in this patient. And I think there was another article I had which was very good. Oh, yeah, it was this one. I'm a big reader. I was reading. Okay, so here, this was non-enzymatic breakdown. So I was reading this. This was the protein in the carbs in the acquired particle could undergo a series of condensation. Now, why I'm bringing it up, I'm trying to relate it to that oral hygiene thing that I was speaking earlier. Yeah. Right? So sometimes we said that halitosis that we see is if a patient has oral hygiene issues, if they have, deposits, because they're showing you lingual surface mostly or palatal. So they said that, and at the same time, if you have a pellicle, then that's where the chlorhexidine can stain it as well. So acquired pellicle could undergo a series of condensation, polymerization reaction leading to discoloration of the acquired pellicle, and chlorhexidine may accelerate formation of those. And that's what causes. No, chlorhexidine doesn't cause dry mouth, but patient was using chlorhexidine for dry mouth. So that's. So dry mouth is a separate thing. Let me open that up as well from TG. So dry mouth is separate. So there's a lot of medications that causes dry mouth. And where is it? Dry mouth here. So I'll go through this one. So dry mouth in this patient was for three reasons in fact. One, patient was taking lots of coffee. All right, anxiety was there, number one. Okay. Number two, this patient was taking coffee. Coffee causes dry mouth. We know that. And the third thing that was the medications that the patient was taking, antidepressants. So this was our biggest issue, which was causing dry mouth for this patient. All right. And now patient said that I'm using chlorhexidine. I googled, and Google showed me that chlorhexidine is good for dry mouth, right? So that's where the problem comes. So I'm just gonna go with the pen. Where's my pen? Where did I put it? Okay, I'll just write it down as well.
The chlorhexidine has alcohol inside it. Would it be
Not
possible
always.
that? Not always.
No,
As far as I know, it always has, because it has to. I'm not so sure, but what I know is it has. So let's say if it has alcohol inside, or we might ask the patient which type is he using, because sometimes they have alcohol, so they might have a role in the dry mouth.
See, chlorhexidine, it has more to do with staining in this case, I would say. Now, alcohol has been quite controversial. I know it increases the shelf life of different types of mouthwashes. But, there's a lot of people out there that are worried about cancer and things like that. Right? So there are versions. There's one Savacol, I think, that they come without alcohol as well. But what I'm trying to say here is, what chlorhexidine was doing here was, so if I go back, how did it all start? So what was the story here? Let me bring on this paint again. Paint. Okay. Where is it? Okay. So this patient the story started with stress. All right. So the patient was stressed given the high role that this patient had. Now, what stress did was, now, when the patient gets stressed, what happens? You tend to see behaviors, that that might be further compressed. So when the patient got stressed, patient started two things. Number one, increasing the amount of coffee, and also, like this. Patient was, what else was happening? Now, patient was using chlorhexidine for 2 years for dry mouth. Now, stress, you know that it causes dry mouth, right? Coffee causes dry mouth. I think I should just put it like this. Okay. So, and then, I think from here I'll write down coffee. So, coffee, they will basically affect. So, coffee was causing dry mouth, and patient was using it. Now, what was also happening in this case was that patient was started then taking antidepressant on and off, not regularly. So the other thing that patient started taking was antidepressant. So there's two things. For the stress, and then for dry mouth. No, this was actually, sorry, please excuse my drawing. I need to remove it. I was making a flow chart. I just didn't get a chance to do it, but I'll make a flow chart and I'll share it as well on the portal. So for the dry mouth, patient was taking chlorhexidine mouthwash. Now that's the problem with this mouthwash. This mouthwash is not given for dry mouth, but patient was using it for wrong indication, and yet the dry mouth was because of antidepressant, because of the coffee, and because of the stress. And now for 2 years, patient had halitosis. Now, patient was not bothered about dry mouth. What patient was concerned was halitosis, right? Now, what happened? Patient was main concern was staining, and number two, halitosis, bad breath. Now, what caused bad breath in this case? So, bad breath in this case. Now, when somebody's stressed, would you expect them to have very good oral hygiene? I wouldn't. Right? So this is what I was bringing you back to TG. So what does TG says? It says that, of course, chlorhexidine is really good. It absorbs onto oral surfaces, so it's effective over a prolonged period. It prevents, now remember, on a clean tooth, right? But it does not reduce pre-existing plaque. This patient hasn't seen a dentist as well for a while. And why lingual surfaces? You know that's where the saliva is,
and oftentimes people don't brush in those areas as well. So it prevents plaque, but the pre-existing plaque, it doesn't reduce it. And now what will happen to those pre-existing ones? In fact, sometimes it can even increase calculus formation. And it even causes, as I was showing you in this article, even further staining of those calculus that were there, reaction that we see. All right? So now, at the end of the day, where are we coming back? Caries and perio. Same thing. The world is round. No matter what topic you bring, it's always caries and perio. We come back to it over and over again. So they're not talking it directly to you. Dry mouth causes caries and perio. What is that stain on the tooth? So that stain on the tooth could be a deep, it could be a stained pit and fissure. It could be, again, a restoration, because one of the examiners was not giving a very clear-cut answer whether it was restored or not. So sometimes the restorations, they will also get stained, so check the areas around it. But now they are expecting us to examine this too. So the first thing for me is this really a staining because of chlorhexidine, because of the coffee, or is this caries? So this is caries. This side was calculus that got stained. Two problems: caries, perio. Same problem in this patient. So your job is to now examine the patient, and you do necessary tests. Now, what additional? So the test that we normally do is, of course, you need to examine patient's mouth. So first thing I want to rule out is, does this patient have a habit of mouth breathing or not? Right? Just to rule out, because dry mouth was one of the factors. So I will look at the lips, how they're closing. Sometimes, having a plaster. Now, when you're looking inside the mouth, what I would be looking at, of course, all of the teeth, especially the one that the patient is worried about, the ones that are stained. And what do? You run your probe. This is your cluster 1. They're expecting investigations from you. So what we need to do is first clinically observe, and then the next thing you need to do is run your probe to see if you can find any catch there, if you can feel anything around those areas. Now, what also we do is, look at it, this is what we do. The areas, because should I be going with preventive resin restoration? Should I be drilling into it, or should I just fissure seal it? So see if you can. Sometimes it's just simply stained pit. One is that. Interproximally, because they were saying the stains were going all the way here as well. We also do transillumination as well. Transilluminate the tooth if you can see anything around that area. And then you will check for the plaque. So those were calculus deposits that got stained. I will check those ones, and also saliva test. Now this is a case of dry mouth. You need to do saliva test. Which test are you going to be doing? Which one should we do?
Unstimulated.
And how would you do that?
Just like relax the patient and pull the lip and notice the time for the saliva come out from the minor salivary gland.
We can give him a cup and he can spit for 5 minutes, and we will measure the amount of that, and according to the chart we can see how much dry mouth or normal salivation he has.
Yeah, there's going to be, these are good tests. How about we go with a simple one? The first thing is, can we just observe? You see? So when you're observing the tooth, you're observing the gums as well. And this is the lips, right? So this is the scoring of the minor salivary assessment. Now, we're trying to see those. So what do? You stretch the lips. Do you see normal lips? Do you see that's like shiny? Versus if there's a dry mouth, you see dryness in that area.
I mean, of course, there's different techniques you can use this. I'm just trying to keep it simple from exam point of view. Remember, we have that athletic patient diet. What did they say? You examine the patient, the saliva was thick and frothy, right? This observe. What do you see here in the patient's mouth? So I would be checking at the gums, and then I will stretch the lip to look for the minor salivary glands. Sometimes we might place these as well if you want to, a gauze, but there's too much. I'll just stick with two things. The next thing is I would be looking, observing. This is the unstimulated saliva. Is it fluid? Is it rotary? Is it like, frothy or bubbly? That will tell you. So if it's thick, ropey, or frothy, that's a red flag. If there is no visible pooling of saliva, it's yellow, and then watery with pooling of saliva. So I find these days ADC is obsessed with TMD and dry mouth for some reason. So that's just my observation. So you guys have to make sure you're good with these two topics. They're just that dentist stomatitis case is probably around dry mouth as well. And now we have this case, and we had that Mehmet case, which is coming as well in the same cluster as well. So ropey, what does that mean? So ropey or frothy saliva has a lower water content, and it is less protective for two reasons. Remember we said it's for caries and perio? So it has lower salivary clearance rate, and it does not form an effective coating on the tooth surface. Right? So just basic. This is going to be too much, from considering from your end to do it. And then along with that staining that is on this side, check for, I would do my BPE charting as well, because that was calculus there that got stained. All right. And then those are the investigation. X-rays are very important. So we'll take bite wings on both sides because I'm seeing this patient for the first time. OPG again is good to have an overall appearance, but it's not very precise. So the focus was these teeth. In any tooth that you suspect, bite wing is good for interproxim, for perio. But for this particular tooth that the patient was complaining, if required, you can go with a PA to see the pits. But yeah, pretty much that's what we're going to do. And last thing, as I said, halitosis. That bad breath that the patient was complaining, either would be psychological or it is because of dry mouth as well. So the first step is reassure the patient, and I will ask to see if they would increase their water intake, cut down on alcohol, coffee, and with the medication as well. I would suggest if they've been to their GP, patient said, no, I haven't been to my GP. And I will ask them why. So this examiner kept saying, I'm very busy, I'm very busy. You can see that. Just like other cases we had, they're very busy. So very important. You need to remind the patient how important it is. They need that medical assessment. All right. So it's similar to other cases that we've been doing, slight changes here and there.
Dr. Nazia, how to explain to the patient that I'm going to assess your saliva? Just say it like this, or should we go in details?
No, just say that, since you mentioned that, your mouth, you've also been feeling your mouth a bit dry. So let me check to see, the texture or the color of your gums, and, might stretch your lips a bit to see if it's shiny or not, or if it's matte appearance. Matte means that it's dry. I will also be observing your saliva, and then whether it's runny or it's frothy or bubbly, that will also tell us if you're dehydrated or not. I mean, I'm sure you can explain better than me. But do you see what I want to observe, if it's watery or clear, or if it's frothy or bubbly? That we want to see. Alright, so this is it. So visually assess, so if it's unstimulated, it's clear in color, watery in consistency. If it looks stringy, frothy or bubbly, or is very sticky, then it may mean that the content of water is low because the rate of production is low. Visual examination is performed prior to a stimulated saliva. Now, what are the other tests normally? I mean, I'm just guiding you. You don't have to say it, but there are different ways of doing it. Sometimes we ask the patient to spit inside this bottle, and then we use the pH strip. That's for unstimulated. So stimulated. So for the buffering as well, similar. We use the pH strips, but I wouldn't get into it. Now, this is what I would do. Assessment of biofilm. It's all about biofilm, and this is my gut feeling that they want to know. So the problem here is that this patient was busy. I would be interested to see how often they're brushing their teeth, right? And also in between. And then they will tell you I'm brushing twice a day. Remember, effectiveness is different. So I will ask them, so do you clean on the inner side towards your tongue side as well? Do you use toothbrush to clean in those areas? I don't think anybody has asked that question. You could be the first one because that is calculus. And then assessing the biofilm is also important. So it says here, the bacteria most commonly implicated in the caries process are these ones. And the matrix of polysaccharide varies in density. So the thicker the biofilm, the more difficult it is for saliva to buffer the acids within. You see? So this patient was not brushing. That thick area was stained. Saliva, which is thick and frothy, use the saliva. It cannot go inside it. It cannot buffer it. Now we have caries probably in that area. So do you see? So it is possible. So they say sometimes you can use disclosing gel. So that's a good idea. Let's use a gel. You can add this. Give this patient a disclosing mouthwash. But it's already stained. But if you want to see those areas, and then double check because that's bacteria is a big problem here. Right? Any questions?
Dr. Nadia, is this the only pit that's involved, or is the effect generalized? Because chlorhexidine would cause generalized staining, no?
So they didn't give you a photo of the entire amount from what I know. So maybe if any of your candidate got this case, can confirm. But they said that from the ones that I spoke with, they said there was 2 teeth they could see. And the one of them had pits, and then it was going all the way on the lingual side, lower, and then the tooth behind it also had staining on the lingual side. So I don't know if they showed the entire photo, but from what I know, they told me it wasn't the entire, that it was just, you could see it was 1 or 2 teeth.
Is this something that we can ask about? Because he has been using chlorhexidine for 2 years, and that would cause like generalized staining on the gums as well, maybe.
Yeah, then what difference would it make?
Like in the preventative advice, we can advise not to use chlorhexidine because that's another reason that's been causing staining apart from the possible decay that we have.
See, yes, but the main thing here is I would educate this patient that if the mouth feels dry, bicarb mouthwash is better, right? To neutralize, remember bicarb mouthwash is the one that you give, it neutralizes the acids. Is what I would recommend. So the focus is caries and perio, right? So they're using, remember in all of the cases, what they say is what they don't mean, right? So this staining and bad breath is an outward that they're telling you, the patient. But when you go below that staining, yes, patient was also having coffee, chlorhexidine was there as well, for sure. But the question here was, what if it's caries? Can be caries. And that staining also highlighted patient's poor oral hygiene. The calculus got stained. Isn't that good? You get to see that. So I would discourage this patient not to use chlorhexidine 100%. From a staining perspective, I say, look, and so one of the reasons was also this chlorhexidine staining the area. Also, the bad breath that you were mentioning. So when you have those
hard deposit which cause calculus. Remember I showed you poor oral hygiene, 90% is because of when they brush their teeth, it gets better. So rather than using a Chlorine mouthwash, we can use a bicarb mouthwash, which is good to neutralize the acid, good for dry mouth, but at the same time, making sure we keep the mouth clean, because you see, poor oral hygiene results in accumulation of plaque and food debris, which can worsen the halitosis. Okay? Oral hygiene. We go back to square one. Brush your teeth twice a day. Show me how you brush. Clean in between the teeth. So those are the ones that we're going to talk about, right? Any questions?
The patient also wanted to know that, can you please do a filling for me? That was one of the questions that he was asking repetitively.
Yeah.
So obviously we do an X-ray. If the fissure is sticking, obviously then I am suspecting it is decay. Then I will be taking an X-ray. And depending on what I see on the X-ray, if it is within the outer layer, then remineralization is enough. But if it's extending deep, then we do a filling.
So see, when we talk about pit and fissure, so this article is by caries detection, sealant, and around fissures. So look at the different categories that we look at it. So sound tooth surface, no. First thing, remember, dry it. I will dry the area to see if I see any first color changes, opacity versus discoloration. Okay, first step. Dry the area. See if you can see any visual. Now, after that, the distinct visual change in enamel visible when wet. Then run your probe over that area, see how it feels, and then yes, you can take an X-ray. So I've had a very good table here. It was very nice. It was risk assessment. Okay, look at this. Detect and diagnose high or low. Our patient was high risk in this category. So then we, as I said, clinical examination. Not only then I'm looking at the tooth on the occlusal, I will also look at the lingual side. Maybe you can, give this patient plaque disclosing in general if you want to check the plaque calculus overall. And then do your saliva test, and then come back, and then do your radiographs, and then based on that you'll see whether it's visible or not. So the question here, that's what I'm saying. Why they were insisting? Because if the decay was going deep into the fissure, and if it is caries, and you went with fissure sealant, that's a mistake. It's a part 1 question. Where you're not sure where your probe is catching, then just make a hole in there small, exploratory, and then we fill it. But where your probe is not sticking, you've taken an X-ray, you've made sure that, then you go with a fissure sealant. It's part of your prevention, right?
Yes. Also, you mentioned to refer the patient to GP for evaluation. So evaluation for what? Because dry mouth is primarily managed by the dentist, isn't it?
It's for the psychological issues.
Okay.
Don't forget, stress, CEO, 28.
Dr. Nazia, this is a cluster 1 info gathering case. What would you recommend asking the patient for history? Like, for example, if he drinks a lot of coffee, I would like to know how many cups, if he sips it all the day, or if he drinks it at specific times.
No, don't go into much that.
We shouldn't go that much.
No, just look. Ask them, so when a patient talks about the stress, like the job, so I would first ask them, does she find her work, being a CEO, how does she find it overall? And then where the stress levels, what does she do when she gets stressed, right? And then from there, I want to get into the social habits. Diet, remember, it's caries. It's also kind of caries as well, assessment that we're doing, right, around dry mouth. So I'll say, okay. And now you'll then, from dry mouth perspective, then you go, so apart from just the staining, you mentioned that you're also using chlorhexidine mouthwash. Now, if I may ask, why are you using that?
And the patient says, oh, because my mouth feels dry, so I've been using it for almost 2 years. Then I would ask, so how did you come across chlorhexidine? I mean, how did you know that this can be used for dry mouth? And patient said in the exam, oh, I Googled it. So I just found out and I've been using since then. Then I asked, has it been helpful? Patient said no. Okay, well, then you explain, if you want to explain now, or you just move on. I'll say, all right, well, look, chlorhexidine generally is not given for dry mouth. There are other things that normally are prescribed, which we can discuss later. But there could be other causes for dry mouth as well. And that takes me to the next question. Given your busy schedule, do you find yourself, like, how's your diet? Do you find yourself drinking a lot of coffee, tea? So go from there. Ask, how much water do you drink on an average? And you also mentioned that you're taking those Lexapro. So how long have you been taking? And then ask the patient, have you noticed? So related. So if the dry mouth started 2 years ago, has this patient been on this medication since then or not? But patient was not regular with that. So this patient needs a proper stress therapy. Was not regular with medication. There's no other solution. So it was same thing like international student, high stress. What do you do? Tell the patient, well, look, we need to. Towards the end, they say, look, I'll check these stains that you're worried about. Now, there's a couple of things I'm suspecting. Either it could be simply sometimes these deep grooves that get stained sometimes, or sometimes, food gets stuck, bacteria, they go there, and then they start to, impact the tooth, and early stages of decay we start to see, which I will confirm. And if that was the case, then we might just remove that part a little bit and fill it. And on the other side here, you were worried. This is probably which will confirm if there was hard deposit. Then we have to look into booking you and doing some cleaning, professional cleaning in those areas as well. But more importantly, we don't need chlorhexidine, right? So explain to the patient that for dryness, bicarb mouthwashes are good. You can make it at home. You can use that. Increase your water intake. Reduce your coffee, and again, more importantly, find a healthier way of managing your stress, because that's not the solution, right? So it's that kind of similar goes with an international student.
Thank you, Nazia. Regarding stopping her medication, like, is it controlled by the GP or she just not taking it? Did any of the candidates ask about that?
Patient was on and off, not taking it regularly.
Okay.
And regardless as well, so if I take you back, sorry, I'm coming with another article. I've got heaps of stuff. Okay, so this reference for everything. So this is Lexapro that she was taking the exam. Now, which is taken for, they say that when to stop. This is from Australian Dental Association 2020. They say that, okay, antidepressants are rarely seized, so if an antidepressant is no longer clinically necessary and requires cessation, withdrawal should only be conducted under close medical supervision with gradual dose tapering over 2 to 4 weeks as outlined in therapeutic guidelines.
All right. So for her, she's stopping and resuming with her medication. It's something we need to warn her about. Like she needs
these antidepressants, they don't work. They work, it's not like stimulants. They have to take it continuously for 2-3 months. Only then it starts to work.
Okay.
All right? It doesn't work like this on and off.
Yeah. One last thing regarding the decay, since we are not so sure if it's stained or maybe it's just confined to the enamel. So is it too much? Because the examiner was asking a lot about, are you going to do a filling for me? Is it important to mention that if it was just confined to the enamel, I would just recommend maybe high fluoride toothpaste or fluoride varnish for now? We can monitoring it even if it's a dental decay, since it's just on the enamel part, or we shouldn't go this far since it's a cluster 1.
Look, you need to go with pin and fissure sealant. So this is what we're doing. So when you have these, so we're going between two options here. Either I go pit and fissure sealant, this is what I teach them in part 1, or I go between preventive resin restoration. Now that's why this is an important topic in part 1. They're failing candidates, so examination is very important. So the primary decision is whether or not a cavitated lesion exists, based primarily on radiograph and clinical examination. So what are the indications of doing fissure sealants? So pit and fissure sealants are prevention, okay? Or for arresting and managing very early lesions, right? Or patients that are high risk groups. It is used in those areas. But what about if a patient already has, let's say I said, like if there's a suspicious fault is removed or found to be sound at shallow prep, what do? Then you explore it and you fill it. That's why they were interested. This is also part of your preventive advice, isn't it? In Cameron, do you see?
So Dr. Nazir, we take x-rays before we decide, right? Yeah.
Yes. You will examine. X-rays are mandatory. It's your +1 either way. So we check it and then we decide if a small carious lesion is detected and the adjacent grooves and pits, although sound at the present time, are at risk for caries, preventive resin restoration may be the treatment. And this is what they're saying, because sometimes the caries is here. Now this is the area. Let's say you seal it from the top, but the caries is here. Yeah, for temporarily it will be fine, but sometimes when there's a leakage, breakage, bacteria will, and then it starts to, and this directly then leads into dentino-enamel junction. Alright, so that's what we do. So look at this. These are all the stained bits. Yep.
Dr. Nazia, I spoke with one of the girls. She mentioned that it was premolar, and I discussed this case with one of the dentists here. So she mentioned if at all we are doing the superficial, you mentioned the preventive resin filling on the occlusal surface, there is a possibility that premolar has a tendency to crack as well. So is it...
Why would it crack?
If you are only putting the composite on top of the tooth, like the enamel part, so there is a possibility that it can get crack as well.
Okay. So what was his suggestion?
So they were saying that if at all the patient is insisting for kept doing the filling, you can make them aware that if I try to do the filling, there is a possibility that it can get crack in future. So do we have to mention that, or?
I wouldn't go now. I wouldn't go that hard now.
Okay.
It's going to be too much. It's a simple case. Look, patient is not grinding. There's no cracks. You're dealing with two things here. Oral hygiene, which causes gum disease, caries. And on the other side, as I said, you want to arrest the damage that is there. Simple. So, yeah, we'll just basically, the question is, should I just put a fissure sealant? Or, how is it going to crack with this tiny amount of hole that we're going to make? Look at this.
Yeah, if it's at all a premolar, not the molar.
Premolar, I haven't come across. Again, I go with the standards. I go with the guidelines because this exam is so. But good, thanks for letting me know. I'm going to double check. I have never come across this ever, but this is a very interesting fact. I'm going to check this out now. I got my dopamine rush. Okay. Yes.
So Nazir, just to clarify and to summarize it. So about the staining, so I'm gonna tell the patient first we're gonna check it visually with my instrument, and I'm gonna check if it's a stain.
Dry it.
Yeah. Sorry. Yeah. After drying.
Dry the tooth. Check the color difference. Then wet it. See, dry and wet. Then run your instrument and see.
After that, we gonna do X-rays, and then depending on the X-ray, if it's of course it will not be cavitated. That's what we are deciding. And then when it's not cavitated, and then we take X-ray and we see if it's we have to do fissure sealant or we have to fill it, right?
Yeah. So once we examine, as long as there is no patch, I will seal it if I was even slightest suspicion, wherever it was, just make a teeny bit of hole and fill it.
Okay.
Okay, so that both are part of your prevention. All right, that's what we do basically.
Yep.
Done. See, easy case. That was it. These cases are easy. Prostate cases are hard. So, okay, so these are like worst possible scenario where we clinically assessing the saliva. Like I said, even when you're visually assessing the tooth, you can visually assess the gums. So if it's dry, you can see it. And then the lips, as I said, we will check. And then you look at for the saliva pooling, and you check whether it's frothy or not. In severe cases, your mirror will stick as well. And a lot of calculus is also a sign of dry mouth. So that's it. We end up back in perio. No matter where you go, perio always comes. Yeah. Or any other question?
Dr. Nadia, before one candidate, she asked about why are we referring to the GP, and he said because of the psychological factor. But what are you going to tell the patient? We cannot tell her directly like that. So what was the best way to tell her why we're referring the
Well, look, I can tell you, being a CEO, psychological issues come. Okay, sorry. No, see again, the other cases where patient was stressed. Remember, we were not sending them to a GP because stress has got different levels. Now, the reason for me would be this patient, remember, was taking antidepressants and on and off. It will have more worse repercussion if the patient is not regular with it. It's even worse, right? So I will say to the patient, I'll say, look, now since you were mainly concerned about the bad breath, which was your other concern now, as we discussed, it could be related to the dryness that you're feeling inside your mouth. It could be related to those hard deposits. So we need to work on, increasing your fluid intake, make sure we are on top of the dry mouth. We're making sure that we're keeping it clean. And most probably it might help in a lot of ways, and it will, you will not have that issue with your bad breath. But if, let's say, you find that not very helpful, I would recommend it's a good idea to also speak to your GP, since you said you're not regular with your medication, you've got a lot of stress going on. So maybe we could look at some other ways of managing your stress. So that's where we go. This patient needs a psychologist.
Okay, so it's for the stress, not for the halitosis. Okay, I got it.
No. She just needs a place to go and vent her problems. That's it.
Yeah, I got it.
That's what psychology. Just go there, vent all your problems, and that's it. Come back out and say, "Oh, I had a great session."
Okay, thank you.
Hi, Nasia, can you hear me?
Yep.
Hey, I wanted to ask you something. It's not about this case. So when I go back to my notes, and when we're talking about MIH, fluorosis treatment and stuff, that we rather give CPP, ACP for remineralizing instead of just like a regular fluoride toothpaste. Now, I know that if it's contraindicated, we can still use a fluoride, but what's the main reason for using this CPP, ACP instead of just like a regular fluoride toothpaste?
Oh, it was that for you that you did?
Like, do you know what I mean? Because I had that question.
Anti-fluoride family. Are you talking about that anti-fluoride family?
No. Just in general. Like, let's say we do let's say like a microabrasion treatment, and we then prescribe like CPP, ACP. So, what's the reason behind that, and not just like a regular fluoride toothpaste?
I see. The tooth is made up of calcium and phosphate, right? Tooth mousse is what it helps. So
yes.
When we talk about even in fluorosis, we're dealing with those enamel prisms that are empty. Think about these pipes that are empty, even in white spot lesions as well. So you've got the structure, but inside it's hollow. So what do you do with tooth mousse? You're filling it up.
Yeah, I mean, but you'd be doing the same thing with like with time and fluoride. You can achieve the same result. Isn't that right?
Yes, but fluoride it makes the tooth more stronger. So let me open and show you. Okay, fluoride.
The main reason why I'm asking you is because I can't seem to find like any, like black and white information on that, and I had that question on my test, and
I've got heaps of reference. Let me bring it on. Here we go. Buckle up. So non-cavitated caries of enamel can remineralize, as it says that those non-cavitated enamel lesions, they retain most of the original crystalline framework of the enamel rods. Now, thus they say the calcium and the phosphate ions from saliva. So this is, by the way, Sturtevant page 59. They say they penetrate the enamel surface and precipitate on the highly reactive crystalline surface, and then the presence of trace amount of fluoride ions during this process will greatly enhance the precipitation of calcium and phosphate, making it more acid resistant fluorohydroxyapatite, as we say, right? So this is basically something that will fill the tooth. This is like remineralizes. Now fluoride makes the tooth stronger, right? But you still need this tooth mousse. So if you give tooth mousse plus add fluoride, not only you are filling the tooth, like I said, the white spot, but also with fluoride now it's going to make it more stronger. So here it says, it is thought that, this is from Mountain Hume, page 71, it allows ions to penetrate more deeply, leading to remineralization throughout the body of the lesion rather than just in the surface layer, right? Which fluoride will be more on the surface layer, right? And it can slow the lesion progression, promote lesion regression, prevent new caries initiation, provide additional caries prevention. Heaps of references, right? Anything else? So that's what we do, use it for the patient. Yeah.
I've got a question from combination syndrome case. So there are different versions. It also comes with 4 lower incisors and sometimes with 2 canines. But you also mentioned 2 other versions where 5 teeth are present, 4 incisors and 1 canine, and sometimes it comes with 6 anterior teeth present. So I have this confusion. If it comes with 5 teeth or if it comes with 6 teeth, then how do we go about that? Because I know overdenture is the preferred option, but then do we ask the patient to remove all 5 teeth or just 4 incisors and keep the canines?
See, 6, I don't think so. It has come at 6. Either it's 5, or it's 2, or it's 3.
So if it is 5, then removing the 4 incisors and retaining canine, is it a good option? Or we just ask that maybe specialists would remove all 5 of them?
So again, you have to see how mobile they are, right? So the incisors, if they are like grade 2 mobile or 3, there's no way you can save it, right? And you would never use them as a overdenture abutment either. But for the canine, you need to see, I mean, normally we would prefer to have 2 implants on both sides or 2 natural teeth on both sides. But in this case, if a patient is really keen on keeping it, and the incisors are wobbly, I say, look, these teeth, front teeth, the little ones, would be hard for us to save because, these we can't even use it as a support. So probably those ones needs to go out. But for that canine, the eye tooth, if you want to keep that tooth, I mean, it can sometimes be used as underneath the denture, but I would leave that decision with the specialist. Normally, we would like to have 2 similar kind of foundation on each side, but since you want to keep it, I would leave that decision.
So we keep it vague because one canine also, the alveolar ridge would project out and it wouldn't be an ideal location. or do we give an option of canine with an implant? Is there even an option?
Generally, we don't like one canine, one implant in general. Like, because, the movement is different as well, the PDL versus, the osteointegrated implant. But you can't override patient's wishes as well. At the end of the day, it's the patient's mouth, not my mouth, right?
Yeah.
So don't forget, if you see, like we were talking earlier about the technicals, remember how they're moving away from the ideals? They're giving you guys these rotated truth lines. Critical thinking, checking. So here as well. So if you go with ideal, it's like imagine a parent that, when they feed their child, they make sure the mouth is clean, not a single drop. What will happen? That child will grow up with OCD as well, right? So you need to be flexible. Allow them to make a mess. Give them some space as well. So this is what it says in Corinne's as well. So they say that whenever when you come across that wobbly tooth scenarios, or present the entire treatment plan as a unit, and always tell the patient that, look, talk about the teeth that can be retained. Do not begin your discussion negatively. I do find that a lot in the role play. People say, we can't save your tooth, sorry. So they say that, this creates a negative impression. So make it clear that every effort will be made, whether you make an effort or not. There's no harm in saying it, right? Just say, make it clear that every effort will be made to retain as many teeth as possible. But do not dwell on the patient's loose teeth. So just tell the patient, well, look, these 100%, they're hopeless, they're wobbly, can't. Canine, look, given that we want to have similar teeth on both sides, now you don't have any on the other side, but since you really are keen to keep this one, I'm happy to for a specialist to have a conversation with you whether or not he will use this too.
Okay. And sick teeth, it doesn't come often, or it has never come?
My biggest concern in this patient was not the teeth, it was, can this patient maintain? Caries is again, the world is round. We come back to caries. Can this patient keep his tooth clean? Even as an abutment? Because at least the implant will not have caries, right?
But implants require more regular maintenance than the natural ones.
The tooth will also require regular maintenance because this tooth has two problems: caries, perio. Implant has one problem: perio.
Yeah.
Right? So it's like, when somebody's technicals, when I see candidates, they're using those in endo tasks, they're using those different burrs and not endo Z burrs. So I say you're dealing with two problems. Now you're worried about the floor, you're keeping it high, and then you're worried about the angulation. But if you use an endo Z burr, you only focus on one thing, which is the angulation. That's it. One problem at a time. So with implant here as well, and this case was about a patient that is going to be starting a medication, and about the future. So you cannot convince this patient about removing a tooth, but this caries will be your clinical justification, like to convince the patient. We said, look, you want to keep it fine. That can be an option, but you know how much maintenance it will require? These teeth, can have decay, it can have issues. So as long as you're ready to take the responsibility, maybe specialists might consider. Or alternatively, with implants, at least we're not worried about caries. That's how you convince. All right. So can the patient family history? No, Simran, don't go into this. Is not a kid. This was a 28-year-old lady. Don't go into the family history in this case. I would go into the social history, like stress kind of things and around the stress. Liver, kidney can also cause help. Don't go just deep into kidneys. We have got kidney issue in that perimplantitis case. That's one case. Don't bring it here. Keep it simple.
Dr. Nadia?
Yeah.
I have a question. We have now two scenarios, right? One is combination syndrome and one is the new flabby ridge case. So in that case as well, like in upper arch, the last two posterior teeth, they are grade 2 mobile, and we are giving an option of over denture with the like 2 implants in anterior region, right? So my question is, can we give an overdenture like which is taking support from both implant and teeth? Is it a practical option?
No, look, again, there is no practical. Again, we're going back to what does the patient want. You see, sometimes we really make those choices that, remember how we did like in VRF cases, what did we do? We're doing putting an occlusal stop. Is that even a treatment? Right? Or we're doing it in that patient, in that situation, it just makes sense. Now, I'm just going back. What was the topic, sir? There's something that popped up in my mind. Oh, yeah. There was an article. I found something very interesting. Okay, let me open it up. There was an article about RPD, and I found a different type of denture, which was a window denture. I don't know if they do it here or not. So that was also an idea that they have done. It was a very nice BDJ article. And they said for those patients that are very keen to keep their teeth, they made a window denture. No, but I wouldn't go into that. So in that case, just tell the patient that we are going to, ideally it should come out. But if you're really keen to keep that tooth, I'm happy to, refer you to a specialist. They might have conversations with you regarding. So this is the window denture. Look at this. How many? Have you guys seen this? This was a patient that was keen to keep this one tooth, and this is a window denture. No, but we had 2 teeth, not one. So even, do you see the reason I was showing you that if a patient wanted to keep that one tooth, even for that, there is something that exists. This is how considerate they have been. And yet here, our patient had 2 teeth on both sides and really adamant to keep it. So let it be. Okay? So there's that was not a big issue. The main issue in that case was this patient had lost teeth because of severe trauma. Now, since I was teaching Part 1 candidates as well about occlusion, my biggest worry was aesthetic. How are we? So I think I'm just going to show you something here. This was another article. Okay, this is called Starts with the Face and Not the Lips. So now, aesthetic means now where are you going to be setting up those teeth, right? Now, this is important for this patient. This part was extremely. Remember, this patient was saying that my teeth are not visible and I look old. I've got colitis. And now this patient lost all of these teeth because of the trauma. And there was something very interesting. One is how are we going to take an impression, and the other problem was how will you set those teeth? Let me open the slide here. So imagine this is what happens in trauma, right? So this patient lost so badly. Patients have lost all of them in trauma. So we call this this is from BDJ, and BDJ says that there's number 1 stage was impression issue. Number 2 was jaw registration stage. That will be very tricky for us in this patient. Now patients, normally what we do is when we do the jaw registration stage, we make sure that the incisal and the occlusal plane of the upper denture, they are parallel to the interpupillary and anatotrigal lines. But in certain patients, they have significant facial asymmetry. Now, they are not showing you the photo of the patient. So, what are those scenarios? Facial palsy, craniofacial, severe trauma. Now, this patient lost a molar to molar. That was pretty severe. So, and what does the patient tell you? I can't see my teeth. Now, yes, the patient cannot see the teeth because of flabby ridge. There was uneven forces for sure. But at the same time, the bone that was lost as well because of the trauma possibly. Now, in these patients, even at the jaw registration, do you see? They said now the clinician should deviate from this keeping it parallel. Now, it needs to be made in such a way that it's slightly, inclining down. Now, that's, again, problematic. So what do you do in the exam? Tell the patient that, when we make you these dentures, we do it in different stages. Now, in the stage 1 is where we check if there is any surgery required, if there's any tooth that we want to keep or we want to remove. This is where we want to make sure the foundation is stable before we take a mold. In your case, a couple of issues I'm looking at, which was the flabby ridges, since the bone underneath was changing into fibrous tissue, and then at the back the tooth was wobbly. So still, we can take a mold, we do it a 2-stage technique. So you take it with alginate, stage 1, and then we make a hole, window technique, and then you do in that area, selective impression technique is what we call it. But the problem with that is, as a general dentist, if you apply a little bit more pressure, it will not be giving you accurate mold. So, okay, even if I try doing that, then comes the next phase when I send it to the lab, and now when we need to also assess where we need to arrange your teeth, since you mentioned your main concern is you can't see your teeth. And now my biggest worry is the amount of bone that you've lost, whether it was because of the denture you've been wearing, whether it was because of the trauma or the flabby ridge. Now, it's important that when we give you a denture, not only it, helps you with your lip line, but also your teeth are visible. Now, that again, is not an easy task to do in your case. So we are referring this patient to a specialist. That's why. Overdenture is the way in this case to go. All right. So I think recently in the exam it also came as a grade 1. I heard about it. They said it's a grade 1 mobile. They're changing it 1, 2, 3. I heard about 3 as well. I don't know if it's just candidates. I mean, not directly from the candidate. I haven't spoken to anyone about that grade 1, but I just heard it. All right, that's it. So we've over that. So, okay, let's finish the session. If you have questions, I need a break, and then we can continue. But yeah, so any of those articles, if you need, I'm happy to upload it for you. And then now you've got plenty of stuff to read. And hopefully, as I finalize this, if you have more information, let me know if you have seen the photo. I'm looking for this photo for the stained teeth. I'm trying to see if you have. Please share with me. Otherwise, I'm speaking to the candidates as well. All right, thanks, guys. Have a great